Dr. Fielding has just laid out all of the issues that we need to deal with today in this conference. It was just perfect, and particularly that graphic in the second slide where he showed health outcomes and what we need to do. So this panel is going to be dealing with designing cities for women. Though he only attributed 10% of the health outcome to that, I think we could redraw that graphic because he did, through his words, redraw it and showed you how important to people's living, women's health, various other aspects are that have a physical basis. And that's what we're going to talk about today. We have with us three fabulous speakers. Our first speaker will be Brian Prestwich. Dr. Prestwich is an assistant professor of clinical family medicine at the Keck School of Medicine at the University of Southern California. He received his undergraduate degree at Stanford University and then attended the UCLA David Geffen School of Medicine. And he completed his residency in family medicine at the Ventura County Medical Center. And 8 years later, he has joined the faculty at USC, where he has taught and served as medical director from 1998 to 2005. He returned after 2005 to the USC California Hospital Medicine Residency as a medical director and chief officer of the Department of Family Medicine at USC. And he is now in year 2 as a project director of a transformation collaborative, very heavily funded, with a grant from LA Care, where he continues to practice and teach systems best practice and practice redesign strategies for transforming the clinical practices of women's health. He has been active in the design and development of the Greater Los Angeles Care Innovation Corridor, which is a virtually integrated system of healthcare and health coverage led by the University of Southern California, the Catholic Healthcare West Methodist Hospital of Southern California, and the Margolin Group. And he is now serving as a strategic planning steering committee for the Keck Medical Center at USC. He is going to talk about his work in this area and lay out the foundation for our discussion today. Dr.
Thank you. Good morning, everybody. It's nice to be here. I'm very comfortable to have 3 sisters, 5 nieces. I'm delighted to be here, and it was really interesting listening to Dr. Fielding. He really teed me up because I'm speaking to you as a family doctor. Many of you may not realize that there are family doctors in the country still. It's actually a 3-year residency training program. But I find we do end up often explaining to folks what we do, and hopefully many of you understand that family medicine is about caring for families across the entire life cycle. So it gives us a very unique opportunity as physicians and stewards of folks' care and stewards of the health of the community to intervene, in all levels of the life cycle. In particular, when you think about the wellness of children who grow up to be adults, preconception, we can actually intervene at preconception at through the prenatal period and postnatal period and beyond. And so that's sort of the perspective I bring to you. I've spent my career in the safety net working with some of the most impoverished populations that we have in the U.S. And right now I still work with the folks that live in the Pico Union District of LA. And so I come to you with a perspective of frankly, a pretty frustrated primary care doctor, having labored for my last 25 years in a system that simply doesn't support my efforts and the efforts of those who I work with. So I'm just gonna give you a little bit of an outline of the things I'm working on. I'm hoping that it'll stimulate all of you, because you ultimately are going to be the agents of change that help get this work done that leads to healthier communities. So I have to start with a joke, of course. These 2 old duffers are driving home from their golf game, and the guy in the passenger seat sees a red light coming up, and they go right through it. And he thinks, that's unpleasant, but I'm sure he just didn't see it. And they come up to another traffic light, and it turns red, and they go right through it again. And he thinks, gosh, he must just be having a bad day. 3rd light comes up red, they go straight through it. He turns over and says, Kenny, do you realize you just ran through 3 red lights? And Kenny turns to him and says, oh my goodness, Jim, I didn't realize I was driving. So as a family doc, that's what healthcare in America feels like. And when you think about it, healthcare in the U.S. since post-World War II has really been, physicians have, as you know, it's been a physician-centric game, right? The other healthcare professionals who we all need to be successful, the nursing professionals, the occupational therapists, the PAs, physical therapists, behavioral science people, social workers, have not had as much opportunity to influence the system. The system's been essentially developed by mostly white men and mostly specialists who are very good at what they do but don't know a whole lot about community determinants of health. So we're needing to redesign that now, and Dr. Fielding laid it out really beautifully, I thought. Something that his colleague at UCLA, Dr. Neil Halfon, has called Healthcare 3.0, which is getting beyond acute care and even getting beyond, sort of the HMO model, which is important, which is the concept of emphasis on prevention, right? Prepayment to help control costs, and large infrastructure that supports all of us who work in healthcare and who work in the communities. Beyond that, Dr. Fielding described 3.0 better than I can, and that is really paying attention to these things like clean air, access to healthy food. So I've gone through my career as a family doc really focused on how do we improve the clinic. And it's only in the last few years, and partly due thanks to Dr. Halfon and some of his colleagues, that I've come to understand that I have to work just as hard at my linkages with the community and my colleagues in the community who ultimately do the real work, right, Dr. Fielding? When the patients leave our clinics, everything falls apart. We work really, really hard to do good screening, and just like he described with his medical student level presentation, by the way, outstanding, very detailed. We can break it all down. We can spend extra time and get in trouble with our CMOs because we spend too much time with patients. They still go home, and it's difficult for them to manage their own care, and it's difficult for them to access the people who can help them. So that's one of the things that I'm working on. I wanted to give you a message of hope, and that is that I'm the first one to criticize healthcare reform in America and what Congress was capable of passing. But in my life, working with the safety net, the Recovery Act and the definition of meaningful use that says that if you don't provide care that is meaningful and useful to your patient, you will simply not be paid by 2016. And the Affordable Care Act that defines team-based care, non-physician-centric care, is including 30 million more people, all the things that you already know. Those two pieces of law have changed my professional career and given me hope that by the time I'm too old to practice, something useful will be happening for the people that we all care about. I will just say that what we're all about in primary care are what are called, and I'm kind of speaking quickly because we don't have a lot of time, but I wanted to get this message across so you can help us. We're trying to deliver what were defined by the great Barbara Starfield, a family doctor and public health professor at Johns Hopkins, as the 4 pillars of primary care. And Dr. Fielding mentioned one of them. The first is a personal relationship with a physician over time, but it's no longer that. It's a personal relationship with a physician and a interprofessional care team over time. There's solid evidence in the Cochrane database that shows that care is better when it's delivered through a care team, right? Okay. Second, access to care, something Dr. Fielding mentioned. Third, care must be comprehensive. And when I mentioned the advantage in family medicine of life cycle care, I think it's pretty clear to folks that comprehensive care is better for everybody. And if you have to develop that virtually because you're dealing with a lot of other healthcare professionals, that's fine, that's part of the game. But we have to use the best new informatics infrastructure and virtual care concepts to make sure that the linkage is really just seamless, okay? And then the fourth concept, which you all are sensitive to, is coordination of care. And coordination of care is used in anyone who has a special needs child or an elderly parent or family member. And since you're the one who, obviously you're here, so you're the one who takes care of everybody. You're taking care of Grandma and Aunt Bess and going through the torture of trying to negotiate the healthcare system. Okay, so the bottom line, my bottom line message to all of you, back up for a moment. A couple projects that we're doing in the clinic that I think you'll find interesting. One of them is called early developmental screening intervention. And again, Dr. Fielding mentioned Maria, and I believe her son is a year behind his school. What we're doing is redesigning how we do well child care so that it's a more family-focused visit, so that we elicit from the parents what their concerns are. I'll tell you something, I've worked with the most challenged parents, in the U.S., and it is difficult for me to find a parent who is not the expert on their child. And some people would say, well, out in the poor areas, that's not going to be true. It's absolutely true. We use parent surveys to guide us to focus the visit because the parents are the experts. They're the ones that tell the doctor there's something wrong with Johnny, and the doctor says, well, he's walking fine, don't worry, it'll be okay. And by the time Johnny gets to first grade, there's a huge problem. So we're identifying the children, we're screening them with structured developmental screening tools that are validated, like the ASQ, and then linking them to the services they need. So we find them when they're 2 years old, not when they're 5, and their brains have changed and they'll never get better, right? So that's an example of total redesign of how we do primary care. We also have a perinatal mental health pilot that we're running where we start screening women actually pre-conception for depression. And if they screen positive, we do a full psychosocial mental health assessment and enroll them in a care team model, an interprofessional care team model. We meet every week in my little clinic downtown. We have a perinatal psychiatrist and social workers and psychologists and occupational therapists and physicians, and we do a care plan together. And there's a case manager who is a social worker, actually, who follows the patients, and when things aren't going well, will inform us, the primary care doctor, that a lot of times our patients aren't doing well and we don't know it. And these people come back and tell us, and we can reestablish a more effective intervention. So my final message to you is indeed that I think the fix is in, finally. We have the legislation, it's passed, and it's up to all of us. Again, the real agents of change here are going to be individuals like you who are sitting in little planning rooms at community clinics or big planning rooms at the county level or the state level, and when someone says something that is not patient-centered, is not, community-centered, says, is that patient-centered? Is that going to actually help Maria or not? And expose them that, they may be well-meaning, but they haven't thought through it and they're compromising. And make them work harder. We have plenty of evidence. We know how to do it. Dr. Fielding described it. So don't give up. Push hard. Last thing, I have a lot of heroes who I read about in history, and a couple examples for me are John Adams and Franklin Roosevelt. And the truth is that the women who they were married to were probably more remarkable than those men were. And those of you who have read about those men and read about those women know that they wouldn't have accomplished what they accomplished without that woman beside them, as Dr. Fielding said, really, really ultimately making the difference. And I really believe that. I'm not pandering to all of you.
Well, I don't know.
I did grow up
about
with three girls. So ultimately, we can get it done, and women will probably get it done. And it's going to be an interprofessional effort, and I appreciate your allowing me to speak with you today.
Thank you, Dr. Prestwich. Now we're going to turn to one of the outer rings of Dr. Fielding's speech, and that was the talk about policy. We're very happy to have with us Paula Daniels, who is the senior advisor to the mayor of Los Angeles on food policy and special projects. Remember those allusions to the chips and the sodas? Well, we're going to hear how that's going to be eliminated through the work that Ms. Daniels is doing. She's trained as a lawyer. She's worked for years in prize-winning work in environmental remediation, particularly in her work with the California Coastal Commission, for which she received many, many awards, the Bay Super Healer Award, the League of Conservation Voters Award in 2005, and the Water Quality Leadership Award from the California Los Angeles Regional Water Quality Board in 2007. She's a real star in that area, but we want to hear about her work in food security, because there's some very positive things that you have done that we're hoping you'll tell us about.
All right, thank you very much. Good morning, everybody. So how many of you live here in Southern California? All right. How many of you live in Los Angeles, the city of Los Angeles? All right, very local people. This is great. And when you're in Southern California, are you talking about Orange County as well as Riverside? Orange County, Riverside, those areas, Ventura? Where else if you're not from Los Angeles? Inland Empire. Anyway, where's that? All over the country. All right, great. Well, it's good to see you all here. And the reason I asked that question is because we are trying to do in the mayor's office with the Los Angeles Food Policy Council to answer that question of whether we can one day be a good food instead of a fast food nation for Los Angeles. And when we think about what that means, it's a very regional question. So I assume, how many of you have read Fast Food Nation by Eric Schlosser or are familiar with that book? All right, so you're familiar with a lot of the concepts. I bet a lot of you have read Omnivore's Dilemma, right? And you shop at farmers markets. I bet if I asked how many people, yeah. So the basic concept behind what we're trying to do is really bringing a lot of those ideas together and trying to turn it into some kind of action. So I'll tell you a little bit about how the Los Angeles Food Policy Council got started. And you might wonder, how does somebody who has a background in water, and I have a very deep background in water policy in the state of California, how did I get to food policy? It's inextricably linked, actually. I sat on the board of the Bay Delta Authority. Some of you who are in California, and if you're from Northern California, you might in particular be familiar with that. That's a body that deals with the transport of water from Northern California down to Southern California. In California, we have a very interesting water picture. Most of the water's in the north, most of the use of the water's in the south, but actually, the real important part of that story is that 80% of the water in California is used for agriculture. So, you know, even with all the water conservation that we do in our cities, and we've done quite a bit, I mean, this is a little bit of a digression, but in Los Angeles, we've increased the number of people in the city by 1 million in the last 20 years, but we haven't changed our water use. That's because we've been doing a lot of good work on conservation. But our agriculture water use is still impacted quite a bit. There's still a lot. So I was sitting on the Bay Delta Authority board, looking at water, looking at the uses of water in agriculture, thinking a lot about our food system. And I also happen to have a background that I guess informs me. I'm from Hawaii, and my father was raised on a sugarcane plantation. So our family there on Maui, the Daniels family of Maui, we were all raised on sugarcane plantations. And there's a bigger story behind how that even came to be. But let's just say they were all raised on sugarcane plantations. So my grandfather spent his time working in a sugar mill, milling sugar that we never could eat. It went from being grown in Hawaii, being milled to a certain degree in Hawaii, and then sent to California for refining, then sent back to Hawaii for purchase. That was C&H sugar, California Hawaii sugar. So that actually in some ways is the story of our food system. It's grown in monoculture. It's grown, you all know this because you read those books, in industrialized, sort of consolidated types of farming. And then the people that live in those regions actually don't get a chance to consume that food. In Hawaii right now, where the obesity rate of Native Hawaiians is 3 times that of the other populations in Hawaii, because they're eating a lot of junk food. So in Hawaii right now, if the ships stopped coming to Hawaii, they'd be out of food in a week. That's because 95% of their food is imported. And guess what? That's true for here, for Southern California as well. Even though we're very near the biggest production of healthy food, fruits and vegetables are grown more in California than anywhere else in the country. And particularly in Southern California, most of our food lifts up into this global food system. So, farmers markets. The Los Angeles Food Policy Council was formed out of the 30th anniversary of farmers markets, and I was working in mayor's administration, very interested in food policy. We were looking at what could we do to celebrate this very important milestone. When you think about what farmers markets are, the point of them was to bring food from, or to give an opportunity, an economic opportunity to the small-scale local farmers who were struggling in this industrialized food system, and to get it to places that weren't getting access to food. That's our food system. There's inequities in it. It actually works quite well for you and me. I mean, we have access to food, but there's struggling ends of this food system, and it's the smaller scale farmers and it's the low-income communities. So how do we start addressing that? And farmers markets were a way to do it a long time ago, but it doesn't make enough of a dent in that food picture that Dr. Fielding pointed out to us before. How did this start happening? I mean, it really was in the 1950s with sort of the Mad Men era of increasing industrialization, but also advertising and getting folks to buy, you all know this because you read the books, right? And you live it and I think you understand it, all those highly processed foods. So how do we start making shifts? How do we start making what a farmer's market idea is into something that can really start creating major fulcrums of change? So you change that percentage of 5%, that's our best estimate, of the amount of local food and that's being bought locally, but also start changing that picture of what people in low-income communities have access to. So we created the Los Angeles Food Policy Council. So the Los Angeles Food Policy Council was a way to work across the different silos and to come up with some policies and frameworks and some initiatives that we hope will start making those changes. And I'll tell you about those in a second, but just briefly, the structure of the Los Angeles Food Policy Council, for those of you who live here, you know that the city of LA is a really different kind of city to run. In New York, Mayor Bloomberg has control of the schools and he has control of the County Department of Public Health. So he can, in that mayor's structure, can set policy and have it be enacted. Dr. Fielding, we would love to have Dr. Fielding be part of the city of LA, but the county is a separate entity altogether, right? So in the city of LA, we know we don't have the County Department of Public Health. It's run by a separate board of supervisors. We also don't run the school district. That's run by a separate board. So we created the Food Policy Council to bring all these folks together into one room. So on the Food Policy Council, we have one of Dr. Fielding's colleagues, Dr. Paul Simon, who's the Director of Chronic Disease and Injury Prevention. We have the Food Services Director for the LA Unified School District. We have the USDA. We have farmers. We have two farmers, Phil McGrath, who's an organic farmer in Camarillo and on the Ventura County Farm Bureau. We have supermarket owners. We have the advocacy groups that deal with health and nutrition, like Policy Link, California Food Policy Advocates, et cetera. So you can see how it works. And then we have a larger network space where we create working groups and subcommittees to help work through various issues. When we have our network meetings, we have about 150 people showing up every other month because they're coming to work on these issues. They care about it. There's a lot of people who are invested in this. And we have working groups on school food and gardens, on good food procurement, on street food. Actually, there's a group that's looking to get healthy food vending into street carts. And then we also have farmers markets and so on and so forth. So one of our key, the one that I want to talk to you about, the one that is sort of our crowning achievement for this year, and Dr. Fielding was there at the moment this was signed into law for the city departments of LA, is our good food purchasing policy. And on October 24, which is Food Day nationally, Mayor Villaraigosa gave a speech in the rotunda of City Hall and signed an executive order directing all the city departments to adopt this good food purchasing pledge and guidelines, which we have developed through the Los Angeles Food Policy Council. And it's the first ever of its kind in the country, and I have a cataract, I can't see that sign. Sorry, 1 minute, okay, she's holding up a sign, but I can't read it. I just saw that it's red. Sorry, it's a function of aging, that light. Okay. Anyway, I just am so excited to tell you about this because it's a really big deal. And we actually also had it adopted by LAUSD. So what this is it's a very comprehensive guideline that has 5 components. It works almost like LEED certification does for buildings. Are you all familiar with LEED certification? Okay, so you know that it has this point scale and there's categories, and a developer of a building can decide it's going to be more intensive maybe in energy efficiency, or it might be more intensive in certain areas, but there's a baseline that you have to reach. So we developed this for food procurement. And the baseline is on the 5 categories are local, sustainable, fair, meaning fair labor practices, humane, meaning no factory farms, animal welfare. So it's both an ethical and an environmental issue, and healthy and nutritious. And so the healthy, nutritious sector was to help developed in consultation with the County Department of Public Health. The others we developed with about 100 stakeholders, including the Natural Resources Defense Council, Environmental Working Group, the Fair Labor Groups, all of that. So we have the baseline level of compliance. 15% of food purchases have to hit that baseline level and then increase 2% every year to where in 5 years, 25% of their food purchases meet those minimum categories, and they can have increasing levels of intensity in each of those categories. For example, if they want it to be more sustainable, it could be organic, it could be non-GMO, and there's choices, so they can make choices along the way. But the point is to get major food service providers to start thinking about the choices they make. And why does this matter? I mean, it's voting with your food dollars. The more you start making these choices, the more you can start actually shifting the food system. And I'll wrap up real quickly on this one in a second. I just want to give you an example of why this can matter. LAUSD just adopted this too, by the way, so we're really excited about that. LAUSD has $100 million worth of food. It's the biggest food service provider in the city, and in the state, actually, if you don't count prisons. With $100 million worth of food, 15% of that, what do you think that does to the markets, particularly our local small farms that can, and this is kind of a public health issue. In Ventura, that's why I asked where people were from here. Ventura right now used to be a very diverse crop growing area. Right now, they're growing mostly strawberries and lemons because they're responding to the market dollars. That's what our demand is telling them we want. We want strawberries, we want lemons. If they're starting to be asked to grow more broccoli because LAUSD is beginning to guarantee that they're going to buy locally broccoli, they could start rotating broccoli in between strawberries. Now, why does that matter? Crop diversity matters a lot for soil. Franklin Delano Roosevelt said, a test of the nation is written eventually in how it cares for its soil. And so we do need to care for that. We do need to protect that farmland. But they also, because broccoli is a natural biofumigant, can grow the strawberries organically. Strawberries right now are fumigated with methyl bromide, which is a carcinogen. It's very toxic. So it's toxic to the workers, it's toxic to the environment. That's the kind of change we're hoping to make for our communities. So I'll end with a quote from Eleanor Roosevelt. So I'm going to go from FDR to Eleanor, which is one of my mom's favorite quotes. The future belongs to those who believe in the beauty of their dreams. So we're dreaming about one day being a good food instead of a fast food nation.
Well, that's just wonderful. We're hearing about new practices, we're hearing about new policies, and now we're going to hear from Jacqueline Leavitt about how to effectuate some of these things. Jacqueline Leavitt holds a doctorate in urban planning and is a professor of urban planning at UCLA. She's authored many, many books on gender and on housing, and teaches housing and community development at UCLA. Her most recent work analyzes lost opportunities in the planning profession where it might have taken a more progressive stand on some of the things we're talking about today and about some of the national crises that we're facing. She has a practice in working with the Los Angeles Housing as a Human Right Collective and an international NGO, the HIRU Commission. She is doing research on labor-related issues, including housing needs for home care workers, public housing, and working conditions of taxi drivers in Los Angeles. She is a co-editor of a book on housing cooperatives and author of another one on tenant responsibilities in landlord-abandoned housing. She is currently at work on a book about women and the right to the city. So, Jackie, take it away.
Thanks, Jeannie, and thank you for having me here. I'm going to talk about where are the women in community development, and the short answer to that is that we're everywhere. And I'm going to draw on two examples, one internationally from the Huairou Commission, which is actually a place in the province of Beijing, where women during the Year of the Women were sent when, unfortunately, the leaders at that time thought that women were going to take off their bras rather than work on serious issues. The Huairou Commission is a super coalition. It was formed in '96. It's also a coalition of academics, of professionals, but its roots are really in organizations like GROOTS, which is grassroots organizations organizing together. The Gender Equity Index for 2012 is based on a human rights framework: right to food, right to education, reduce infant mortality, access to safe water and sanitation, universal access to phone and internet, right to social security, sustainable development related to adequate climate change goals. What the Huairou Commission is all about is not only a right for that future, but also a right to community and to community development. Global Coalition has people working in several different areas, specifically disaster, and not disaster and relief, but disaster and redevelopment, disaster and resilience, on land, housing, and finance, not just the building, not just the identification of what is missing, but how do you create access to credit. On HIV and AIDS, on local governance, and I'll talk a little bit more about HIV and AIDS, but let me tell you a little bit about the ways in which the Commission works. All of it works at the grassroots level. The Secretariat is a small body. At the grassroots level, there is something called Grassroots Women's Academies that bring together peer groups who talk about what's worked, what hasn't worked, community-based mapping, local-to-local dialogues, which includes, particularly in countries where customary law is stronger, tribal chiefs, participatory budgeting as a tool, and movement building nationally and regionally. The AIDS project, let me just say one thing about the slide behind me that represents Joka in the front, who's from the Philippines, two women who are from Guatemala, partners from the UN Habitat, which is one of the global partners, and also people from Turkey and from Southeast Asia. There we go. The Home-Based Care Alliance is a bottom-up federation of grassroots home-based caregivers, and it began essentially by women helping women and other members of the family, realizing that AIDS was leaving lots of orphans in parts of the world, and has grown into 30,000 organized caregivers in 11 countries by 2012. It has formed in, clusters have formed in Cameroon, Ethiopia, Kenya, Malawi, Nigeria, South Africa, Uganda, Zambia, and Zimbabwe. And it's based on a peer mentoring method where people, as with the Grassroots Women's Academies, talk about their successes and their challenges. They're trained in the organizing steps to go to the next step of alliances and caregivers action networks. There was a survey done of about 1,400 caregivers and an excellent report that came out with 4 recommendations, and the recommendations have to do, 1, with organizing, 2, with recognition of care work, which, as we all know, is so identified with women that it is sometimes seen as invisible, resources, and remuneration. What's important about the report is that, and I'm only going to be able to talk about a few of the recommendations, is that it's a comprehensive and efficient integration of caregivers into the existing health system. Basically, it is calling for the fact that the health system should recognize that this caregiving is going on, and that there are experts with knowledge about their own communities, that there should be ways of paying for those caregiving, also leading to the possible accreditation, which then means that we're also talking about job development, to support caregivers at that local level, and also to establish that the grassroots women could be monitors and evaluators of health and AIDS programming and funding. In India, there's health mutual funds that have been set up. In Kenya, various clusters are involved with national strategic plans. Moving to, there we go. Moving to Los Angeles. I'm talking about LA and the right to the city, and this is a housing as a human right collective that I work with. The right to the city, for those of you who know the French philosopher Henri Lefebvre, who, as Jeannie and I were talking the other day, doesn't talk about women, so you have to read my book when it comes out. Drum up an audience. But right to the city has come up also with human rights, but human rights that are looked at collectively. Again, going back to the fact that while it's great to have individual responsibilities and individual jobs, the fact remains that unless we build on the existing communities and networks, we don't leave very much behind if we're just the professional coming in. LA is a renter city. I hesitate to ask this audience how many of you are renters, but I am. Some 62% are renters, and the median income in this city is roughly $64,000, $65,000. California is the second most expensive state. The housing wage, which is based on whether you have how much money you earn on an hourly basis in order to afford 2 bedrooms at a fair market rent, is $26.02. $26.02 is about 3 times more than the minimum wage. You would need in the metro city area an income of almost $60,000. People who are poor would have to take 3 to 5 jobs in that household at a minimum wage, working full-time, working year-round in order to be able to afford housing. We are in a permanent housing crisis, and I want to suggest to you that that has impact for a permanent health crisis. The rental housing market the only housing market that has grown has been market rate housing, while rental housing has been in decline. The majority of renters in Los Angeles are rent burdened. A third of them are severely rent burdened. Someone is going to talk later about homelessness, so I just want to mention that the Downtown Women's Center and the Los Angeles Community Alliance Network and others have worked on needs assessments that have shown that on the women on Skid Row, it is impossible to get housing, partly because of the long waiting lists. And as many of you know, public housing is, the lists for Section 8 are closed. There are health issues that have been dealt with and housing issues by a coalition of groups that includes St. John's Well Child and Family Center, LA CAN, Esperanza Housing Community Development Corporation, and SAGE. And the ways in which they have come up with ideas for helping include lawsuits, picketing slumlords, care management, education and awareness, hiring of women from the community as health promoters, identifying issues about asthma and the cockroaches and vermin that carry it. The final thing, because I think you put up a red, did you? Yes, you did. Okay. The final thing is that this group, Housing as a Human Rights Collective, has asked for the fact that the cities should divest from banks that illegally displace tenants, that the city's rent stabilization law should be amended and take into consideration people's financial situation, that landlords should be prosecuted who provide unhealthy, unsafe conditions. Finally, I would just, and this is final, I have about 6 points I just want to make really quickly as take-homes. Support organizing, give to groups that are already working with communities, demand accountability of how our public money is being spent, demand transparency. If we can put up signs about how many hamburgers we eat every day, we can put up signs about how much money is being spent on a housing unit. Have a public conversation, a public dialogue, support public housing, whatever you may think about it. I'll try and convince you you're wrong, because it is the best permanent subsidized, permanent low-income housing around. Don't silo. Look at housing and health together, as well as all the other issues, and see that in a world of globalization, women's futures transcend national and local boundaries, and in the training of future professionals in planning, in the medical fields, in nursing, the art of listening is always one that can be encouraged. Thank you very much.
Thank you, panelists. We've only touched the surface how we design better communities for healthier women. Now I would like, and thank you very much for touching on better care, food supply, and housing, basic elements.